All right, let's get started. So my name is Layla Jamal, and I am a genetic counselor who is a researcher at Johns Hopkins University. And beforehand, I worked at Kennedy Krieger Institute in the Moser Center for Leukodystrophies there. And today I'm going to be giving a presentation about the genetics of ALD and reproductive options available for affected families. But before I get started, I'd just like to make a few announcements. ALD Connect is going to be hosting a patient learning academy on Sunday, March 8th, 2015. And the focus of that patient learning academy will be education about clinical trials, mobility devices, exercise, and diet and nutrition. So if you're interested in attending, please email us at info@aldconnect.org. I'd also just like to make a few other announcements. These educational webinars are relatively new, and we are planning more in the future. So if you're interested in hearing more information about ALD, we do have some others planned, and these are some topics we're thinking of covering. But if you have suggestions about other topics you'd like to see us cover in the future, do please email us again at info@aldconnect.org. So I'd also just like to take care of a few housekeeping issues before we get started. Just as a reminder, for those of you participating today, please enter your audio pin so that you can participate in this webinar after the presentation is over. That's how we know who you are and that you're here. You may also use the question box to send questions that come out through the presentation. We won't identify you by name when you do that, but we will acknowledge as many questions as we can. And if we don't get to them all, we'll try to follow up with you afterwards. And just please note that I'll be the only person able to speak during this presentation. It's also important for everyone to be clear about the fact that this webinar is informational only. The information I'm going to provide is not intended to be a substitute for professional medical advice, diagnosis, or treatment. And so if you or a family member are ill, or if you need immediate attention, please seek professional attention immediately. We don't recommend or endorse any specific physician's treatments or procedures mentioned in this presentation. And please note that your participation in this webinar is completely voluntary and that it will be recorded and may be available for rebroadcast at a later time. So with those housekeeping issues out of the way, I'll just give you a brief overview of what I plan to cover today. To begin with, we'll talk just a little bit about the basic concept of genetics and ALD inheritance. Then I'll go over genetic testing and how it works and what the purposes of genetic testing are. We'll talk a little bit about reproductive options available. We'll talk about this very generally, but so that you can basically get a sense for what the technologies are and how they might be helpful for you. But certainly for any individual circumstances, it would be much better to talk about them in detail with a healthcare provider. And then at the end, we'll talk a little bit about psychosocial considerations and we'll do some Q&A. So just to get started, I will just clarify that, DNA, when I mention DNA, I'm really talking about these small chemical units that are stored in each and every one of our cells in the body. And we abbreviate them ACGT, but those are all different chemicals that form DNA strands which wrap into chromosomes inside the nucleus of each of our cells. And these units basically spell instructions, and the instructions are stored in units we call genes, and these code for the proteins and the substances we need in our body to grow and develop and function. And so when we talk about genetic disease, we're really talking about a mistake in the DNA or in the chromosomes that leads to an abnormality in some aspect of the way the body functions. And that mistake can be a spelling mistake where one of the little chemical letters is incorrect, or it can be a break in the DNA strand, or it can be an abnormality in the chromosome. And different types of genetic abnormalities lead to different types of genetic diseases. So there are about 3 billion of these chemical letters in our genome, and so many, many different genetic tests exist. And in ALD, we're really concerned about a gene that's on the X chromosome called ABCD1, which codes for a protein which is very important in the way we process fats in our body, called very long chain fatty acids. And it's important to realize that women have two X chromosomes and men have an X and a Y. And that just means that women have two copies of the ABCD1 gene associated with ALD, whereas boys only have one copy of it. And that means that if there's something wrong, if there's a mutation in a man or a boy's copy of ABCD1, we tend to see severe problems, or more severe problems than we do in women, because women have this second backup copy because they have a second X chromosome. All of the other chromosomes we have two copies of, both men and women. So this last pair, the X and Y, is what's unique about boys as opposed to girls who have two X's. But otherwise, the rest of our genome is more or less the same. So how do mutations in ABCD1 cause ALD? So basically, ABCD1, that gene codes for a protein which transports these fatty acids, which we call very long chain fatty acids, into a structure in your cells called peroxisomes. Peroxisomes are responsible for degrading those fatty acids, but if they can't transport them in, then they can't degrade them. And so this disabled transport function leads to the accumulation of these very long chain fatty acids in the blood and over time. And that can lead to buildup in brain cells, adrenal cells, and blood cells, which can lead to the many manifestations of ALD over time because that buildup is thought to be toxic. And so this figure here just depicts that process. And in particular, the buildup of very long chain fatty acids is thought to be toxic to our nervous system, and specifically to the myelin sheath, which is the insulation which covers our nerve cells and allows them to do their job and transmit electrical impulses properly in the brain. So now I'm going to talk a little bit about the different types of testing that's available for ALD. Most people who are familiar with this disease are aware that there's two different types of testing. The first is called very long chain fatty acid testing. And this is not actually a genetic test. This is instead looking at the levels of very long chain fatty acid in a patient's bloodstream. The test is extremely sensitive for detecting ALD in boys or men. Because they have a more profound buildup of very long chain fatty acids in their blood if they're affected with ALD. Whereas in women, unfortunately, this test is not quite as sensitive because the very long chain fatty acid buildup in women with ALD is a little bit less pronounced. Genetic testing is the other option for testing for ALD aside from the very long chain fatty acid test. And there are several different kinds of genetic testing available. You can do gene sequencing, which is the most expensive, and it reads through every single letter in the ALD gene. Or you can do deletion and duplication analysis, or you can do targeted mutation testing if you know which mutation exists in your family. Gene sequencing is the most expensive and is not always necessary if you already know that a specific ABCD1 mutation runs in your family. But if you don't know which mutation runs in your family, then you may want to do gene sequencing to find out. All of these tests take a little bit longer and they're a bit more expensive, but they do have the benefit of being more sensitive in women as well as men. The other option for testing nowadays is newborn screening, which was recently introduced in New York State in 2014 for the first time. And this is a state-run program where infants get screened for ALD with a little blood spot test automatically to identify people that might not otherwise be identified until they develop symptoms. So we're very supportive of this, and there are other states depicted in this map considering introducing it. Importantly, if you know of anybody who's newly diagnosed with ALD on newborn screening, please direct them to the ALD Connect website. That's where we archive all of our educational webinars, and there's one especially helpful for families who are newly diagnosed. But this is a relatively new way to be tested for ALD, and it's not available in all states yet. But certainly the hope is that by detecting newborns early before they develop symptoms, we'd be able to intervene most effectively with screening of boys by MRI and with the adrenal surveillance that they need in order to get the treatment that they need ultimately. So now I'm going to transition a little bit to talk about genetic inheritance patterns. And, so I'm going to talk about this. Let me not skip ahead. Let me just back up a bit. I'm going to talk about this in two ways. I'm going to, first of all, talk about it as though we're dealing with a woman who has ALD, and then I'm going to talk about it from the perspective of a man who has ALD. And I'm going to talk about it from the perspective of parents who are thinking of having children, acknowledging that that's not the only scenario you might be thinking about inheritance, but those two cases are kind of illustrative of general principles of inheritance. Although, that's not the only time you might be considering getting genetic testing is when you're planning a family. So the first case is a situation where a woman with ALD is having children and she has a daughter. So as I mentioned earlier in the webinar, we have all of these chromosomes, and it's the last pair of chromosomes, the X and the Y, or the X and the X, that determines whether you're a man or a woman or a boy or a girl. Right? So if you're male, you have XY. If you're female, you have XX. So the woman with ALD has a mutation in ABCD1 gene on her X chromosome. And with every pregnancy she has, she's only going to give one of her chromosomes to her child, right? So there's a 50% chance with each pregnancy she's going to pass on the one with the mutation. And the other chromosome is going to come from her husband. And so you can see here that basically with each female pregnancy a woman with ALD has, there's a 50-50 shot that she's going to pass on the mutation to her daughter. So, and that's depicted in this picture. Similarly, with each pregnancy, if the woman has a male pregnancy, there's also a 50-50 shot she'll pass that X on to her son. And the other chromosome will come from her husband, as was the case before. And so you'll see depicted in this picture that basically for a woman with ALD, she's got a 50-50 shot of having a boy who's affected. And of course, the symptoms in a boy with ALD would be more profound than they would be in a woman, generally speaking. So this picture just depicts the four outcomes overall that you could get. And essentially 50% of all pregnancies of an ALD woman will be affected. And it's just a question of whether it'll be a girl or a boy. And 50% of pregnancies will not be affected. And so it's important to remember that as well. So I think it's important to think about the fact that inheritance patterns matter not just for informational purposes. It's obviously good to understand your risk, but it's also important because the way you inherit ALD or the way you're at risk of transmitting ALD really shapes your perception and your experience with this disease. So some things I generally hear from daughters of ALD women are, the disease isn't that bad in women, so I don't really need to be tested, even though I know my mom was a carrier. Or I'm just worried about my brother right now. I don't really have time to worry about myself. Or I'm never going to be able to have children anyway, so testing doesn't really matter. Or they just don't want to think about it, and that they point out that there's a chance they don't even have it, since there's a 50-50 shot they could inherit it from mom or not inherit it from mom. And so I think these people, there's no rule, everybody responds different, but these people tend to be a little bit more likely to avoid testing or to feel like it's not necessary because their mother might not be symptomatic yet, or she might only be mildly symptomatic, and they know that they're not for sure carriers if their mom had it. So it's just something to keep in mind, that these individuals might require a little bit more of a conversation about testing and about risk if they aren't, inclined to go in and get evaluated, especially since they might have a brother or someone else that they're more worried about than themselves. So the other situation you can be in is obviously if you're a man with ALD, or especially, most often this is a man with AMN who carries the ABCD1 mutation on his X chromosome. His second sex chromosome is a Y, and his wife has a double X chromosome without any mutation. And so in this situation, in order for this couple to have girls, they would both have to pass on an X chromosome each, the man and the woman, in order to give birth to a daughter. And that means that the man, because he only has one X chromosome to give, he's always going to pass on his X chromosome to his daughter if he indeed has a daughter. And what that means is that any man with ALD is always going to have a daughter who's a carrier. There's no other way for him to have a daughter unless she is a carrier. But if he has a son, conversely, he's going to have to pass on his Y chromosome to that son because that's the only place a son could get one from. Mom will pass on one of her healthy X's. And so for men with ALD, they will never transmit the mutation to their son. Okay, and so that's a little bit different than the scenario we saw before. So in other words, for men with ALD, all of their daughters will be carriers and none of their sons. And so this situation is a little bit different from the one we talked about earlier where the mom was a carrier. Some things that I hear from daughters of ALD men are very different because their situation is a little different. So, they'll say that they've known they were a carrier all their life because their dad had ALD, and therefore there was no other way for them to get an X chromosome other than to inherit it from dad. They'll, talk about the fact that they've grown up with this sort of stigma and that they'd rather not talk about it with partners in teenage years because it's kind of difficult to talk about the reproductive implications of being a carrier, and it's not something they want to think about. They talk about a fear of having children because they saw how sick their dad was and they don't want to go down that road with their own children. And they talk about kind of, the fact that they might have symptoms in adulthood and what it's like to think about that as a child. That's a sort of unique situation to be in. So the experience is a little bit different, often of daughters who inherit from ALD men, and it affects the way that they approach testing and reproductive care. Another thing I'll mention, and I'm just going to touch on this briefly, is that there are some people who have ALD because, not because they inherited it from a parent, but because of a spontaneous, so a kind of random mistake that happens in the DNA of the ABCD1 gene at the time of conception or in the egg or the sperm of the parent. And these are really difficult cases because we can't predict them ahead of time, but it's estimated to be a small proportion of cases, up to 7%. And then germline mosaicism is a term that refers to a situation where a parent has the ABCD1 mutation in some of their egg cells or some of their sperm cells, but not all. And this is very, very rare, but it is a way that one could inherit ALD from a parent without actually knowing that parent was a carrier, because you wouldn't detect the mutation in that parent anywhere else except for those few egg cells or those few sperm cells. So these are tough cases, and I won't spend too much more time going into them technically because they're so rare. But if you believe that this is a situation which applies to you or you'd like to hear more about it, we do have people in our community with experience with these scenarios, and we can certainly put you in touch with them. Just please email ALD Connect, and I'll share that contact information again at the end of the webinar. So here is just some rules of thumb, some important things to remember. Not every person with ALD in the same family will always have exactly the same disease. We know that ALD is not purely a genetic disease. Yes, you need the mutation in order to have the disease, but there are other variables like other genes and other environmental factors and other aspects of the body that we know moderate or influence the severity of this disease. And people are still studying those influences and trying to figure them out. But if you have ALD, it's important to remember that what happens to others may not be what happens to you. Everyone is different and needs to go to the doctor to monitor their own version of this disease. Because it really, it manifests differently in different patients, even though it's not good in any of them. And if you're thinking about undergoing carrier testing, just remember there's no correct way to feel about this. Some people really are anxious to get tested as soon as possible, as soon as they learn they're at risk. Other people are more avoidant or less willing. They feel a little bit less comfortable with knowing that information. And just remember that the testing exists in order to help you. It's not there to scare you or label you or stigmatize you. It's there to help you understand if you need to seek treatment, and if so, to do so as early as possible. It's there to help you prepare and plan for the future. It's there to help you figure out what your options are for planning a healthy family. And, for those who don't carry a mutation, testing can actually provide reassurance if you are found not to be at risk. And although, unfortunately, that doesn't happen to everybody, it certainly does happen. And so just to remember that it's possible, not everybody does inherit this. I'll also just say a quick word about issues related to testing children, genetic testing in children is a little bit controversial. For ALD, we do it in boys because we know there are life-saving things we must do for them if they are positive. And that's really a no-brainer. We want to identify all the boys at risk if possible, because there are things we could do really for them if they're at risk of disease. And sometimes we'll do testing in siblings of these boys if we need a bone marrow match. And we're really hoping that that will occur less and less as we identify boys earlier and develop better treatments for those boys. But sometimes it is still necessary. But in girls generally, many clinicians prefer to allow girls to decide about genetic testing for themselves in adulthood. Simply because in girls with ALD, there's no real medical interventions we would do for them in childhood. There's nothing we would do to make their lives better. And many worry that the test information, if they're positive, would just introduce unnecessary blows to self-esteem or anxiety. And I think it's really on a case-by-case basis whether clinicians feel that testing in young girls is appropriate. But either way, it's good to seek counseling first. And just remember that each family is different, so it's important to talk things over periodically and to make sure that children's feelings are understood and to revisit the issue on a regular basis, because if kids are tested young, they may not understand the information fully. They may want to talk about it again when they're older. And that brings me to this other point that I think, family histories are really living, dynamic things. People are constantly getting older and having children and getting married. And so to review your family history at regular intervals with both yourself and your healthcare provider is a good idea, because that helps understand whether there are new family members at risk of this disease who might want to be brought in for counseling and testing. Every few years, it's good to review that. And I'll just include a little bit of a plug here for the National Society of Genetic Counselors, which has a counselor finder tool on the website. So if you're looking to start a conversation with somebody about genetic testing, this is a good place to go to find someone who's local to you. And just remember that a genetic counselor is just that. It's someone you can talk to. Going to see one doesn't necessarily mean you have to get tested, but it's somewhere you could get information and follow up then later, if you want to with testing. So now I'm going to transition to talk about reproductive options for couples at risk. And so it's important to remember that there are different options available to families at different times. You can look into testing, before you ever even conceive. You can do it as part of the IVF process, or there is testing available after you've gotten pregnant. It's also important to remember that there are different options available to you if your ABCD1 mutation is known versus if it's unknown. If you don't know your mutation, then unfortunately, if there are fewer options available to you, you can adopt, you can use donor egg, sperm, or embryo, or you can go ahead and conceive naturally. And there is some prenatal testing for ALD you can do without knowing which gene mutation you're looking for in the baby. You can use very long chain fatty acids. But these options, I think, are a little bit less expansive than they are if you actually know your mutation. If you do know which mutation you have in ABCD1, and I'll just clarify here that people who have mutations in this gene don't always have the same one, right? You can have different kinds of spelling mistakes in the gene. So if you know the specific kind of spelling mistake in this gene that you have, you can do something called PreImplantation genetic diagnosis, where you do IVF and test the embryos for ALD before you implant them. Or you can do something called chorionic villus sampling, CVS, or amniocentesis, after you've conceived, and that's done in utero when the fetus is still developing. The benefits of getting tested before you plan a family are that you can kind of deal with that information and learn about ALD and do all of that before you're actually pregnant or planning to get pregnant. It just, I think, takes some of the stress out of the process to get that done ahead of time. Planning a pregnancy is very overwhelming. So if you feel like you might be planning a family in a few years' time, if you're a woman or a man with ALD, you might knowing your mutation and getting that testing out of the way early might be a good idea. So in the preconception period, one of the options available is egg and sperm donation. These donor egg and donor sperm are available from storage banks. They're frozen. Donors can be tested for any genetic conditions that you request these days almost. And especially ALD, if you know you're at risk, you do have to request that. It's not done automatically in most places. And they'll test for other genetic conditions too. And donors can be either anonymous or known. It really depends on the policy of the sperm bank. And the donor sperm can be used either through IUI, which is a process that basically inserts the sperm directly into the uterus for conception, or it can be used in vitro fertilization, where they make an embryo outside the body and then implant the embryo. And the costs and the rules and regulations pertaining to egg and sperm donation are really variable from state to state. So it's important to go to a sperm bank or a cryo repository, which is where they keep eggs, and talk to them specifically about their policies and their procedures. Nowadays, there's also embryo adoption available, which is basically a process where you adopt an embryo that was created during someone else's IVF process. And that's new, and so it's something to inquire about. The second option is pre-implantation genetic diagnosis. This is basically where you take a normal IVF process which creates embryos outside the body in a dish. And you basically take a few cells from each of those embryos and you test them for the ALD mutation. And then you only implant the unaffected embryos back into the womb. And this was first done in the 80s. It's very effective. It's done a lot. There are some families where it's a little challenging to do this if the mutation is particularly hard to detect in such a small number of cells from such a tiny embryo. There are occasions where, it's not possible to do this, but most people with ALD that I've worked with who've tried this, have managed to get it done. These days, you can also do PGD for any kind of genetic condition, not just for ALD, and so they'll offer you several tests. The procedure is a long and kind of harrowing one. You have to take drugs to basically regulate ovulation in the woman and then retrieve the eggs through an invasive needle process. And then the fertilization of the embryos can take a few tries. Sometimes the egg retrieval takes a few tries. But ultimately, what you want to do is you want to end up with several embryos and perform genetic testing on those embryos and then just implant the ones that are unaffected. And the process is believed to be about 98% accurate, but prenatal testing afterwards is still recommended to make sure that the fetus is healthy and does not have ALD. But PGD, is although it's a good option, it's certainly a difficult one and a lengthy road. IVF is expensive, and PGD, the genetic testing, adds another few $1,000s to that cost. And there may be needs for medication. There may be needs for multiple cycles of IVF if the first one is not successful or if you're not a good candidate for it. It's important to remember that the older you get, the less likely it is that your IVF cycle will be successful. And insurance plans do not always reimburse for every part of this procedure. So you won't know whether they do until you ask. And if money is an issue for you, definitely make sure you do that up front, because once you've started the process, it's very hard to run into barriers or unexpected huge bills. Because it's never possible at the outset of this to really say how many IVF cycles you'll need or how many rounds of drugs you'll need to stimulate your ovaries. All of that is kind of something that you'll have to walk through with the person at the fertility center that you're working with. So the next group of reproductive options that are available after you get pregnant, and those are a little bit more difficult in a way, because you are essentially, if you find out that your baby is affected with ALD, your options at that point are either to prepare to have a child with ALD and to really prepare to look after them and undergo surveillance for them and provide them with the medical care they need, or to end the pregnancy. And those can be difficult decisions, and they're decisions that have to be made in fairly time-sensitive ways. But the goal of these procedures, both chorionic villus sampling and amniocentesis, are designed to look at little samples of DNA from the pregnancy itself, and then to test for the ABCD1 gene mutation that way. So the I'll just quickly clarify here that there are two different kinds of prenatal tests that are offered to pregnant women in the first trimester and second trimesters. And these days, the range of options is so large that it's important just to spend a moment clarifying the differences between these tests because it can get very confusing otherwise. So there are two types of tests that you'll be offered if you're pregnant. One is called a screening test, and the other is called the diagnostic test. The screening tests are really designed to detect a woman's risk of having a baby with Down syndrome or other disorders like this Down syndrome that are caused by a completely different mechanism than ALD. They're caused by abnormal numbers of chromosomes ending up in the embryo or problems with the chromosomes, which are the packages that contain DNA. And screening tests just look at a mother's bloodstream. It's a blood test. And then they determine whether a woman's at high, low, or medium or risk for developing one of these genetic conditions. But it can't tell you anything about your ALD status or your baby's ALD status. The diagnostic tests are more focused on specific conditions, and they provide you with a more certain result. And can be used to detect a pregnancy affected by ALD. But the diagnostic tests are a little bit more invasive, and they involve a needle, usually either in the first or the second trimester. And so those are the tests I'm going to focus on more. But it's important to know that you will be offered all kinds of things if you're pregnant, in addition to testing for ALD. Another type of test I'll just briefly mention is called non-invasive prenatal testing. This has been in the news a lot lately, and it's basically a screening test, just like the ones I described in the previous slide. But this is a new method where the doctor will look at fragments of the baby's DNA in mom's blood and then determine whether the baby is at risk of developing disorders like Down syndrome or other genetic disorders related to problems with chromosomes. Again, this is not a good method for testing ALD, but it's a really new method that's been in the news a lot, so it's important that I mention it. And in the future, some people believe we will be able to test for ALD this way as early as 10 weeks into a pregnancy, but right now we can't. So the tests that are good for detecting ALD in a pregnancy are called chorionic villus sampling, CVS, or amniocentesis. CVS is available in the first trimester as early as 10 to 13 weeks, and it involves inserting a needle and sampling some cells from the placenta or the growing placenta and looking at fragments of the developing baby's DNA from that placental tissue. And they can actually look for the ALD mutation that runs in your family that way. There is a small risk of miscarriage associated with this procedure. Really, it's very minuscule, but different places, different hospitals will quote different rates of risk. But it is a very sensitive way of detecting the mutation. And these are just some, These are just some pictures that are showing you what the procedure would look like. They either insert a needle through the cervix or through the abdomen. So the next test that you could detect ALD on would be amniocentesis, done in the second trimester. This is similar in that it's basically a guided ultrasound and needle procedure that extracts amniotic fluid from a pregnancy and looks at little cells swimming around in the amniotic fluid and looks at DNA from the pregnancy that way. There's also a very small miscarriage risk associated with the procedure, but you can look for your specific ALD mutation using this, and it's a very sensitive method. And this is just a picture depicting what amniocentesis looks like. As you can see, the baby's a little larger, it's a little further along. And there are other conditions you can test for using these procedures other than ALD. So in the second trimester, you can also look at the baby's risk of developing spina bifida by looking at alpha-fetoprotein, which is another substance in the amniotic fluid. You can test for other genetic conditions using either CVS or amniocentesis. But usually families with ALD are obviously more concerned about ALD. But again, just know that, if you're going to go to the effort of doing this procedure, you may be offered other tests along with the ALD test. And so I always put this slide up just to kind of reiterate that these decisions are hard. You never know which test is right for you until you've really thought it through and talked it over. And, certainly timing, I think, is really important. If you've recently lost a family member or, things are not going well in your life, it can be hard to go through these reproductive plans because they involve so many doctor's visits and follow-up procedures. And, a lot of the time, these decisions are really difficult to make. If you have a pregnancy that tests positive, you may need to really go home and think about it a little bit before you decide what you want to do about that. Some people, would feel very strongly about continuing their pregnancy, even if it were affected, and others feel pretty strongly about ending it. And really different families just go different ways depending on their life circumstances. So just, genetic counseling is very valuable, or having a good conversation with your doctor is very valuable because you can go through all of these issues. You can talk about cost and insurance constraints and be prepared up front for the costs that will be associated with these procedures. And you can figure out how to get on the same page with your partner about things like plans in the event that the pregnancy is positive. So that sort of covers the main bulk of the informational content that I was going to go over today. I'm going to transition now because, I think it's really important to hear from someone who actually went through carrier testing as a young woman. And we have a really brave and enthusiastic volunteer from our ALD community named Taylor Kane, who's offered to share with us some of her experiences. So I'm going to play a segment now that Taylor pre-recorded for us earlier, and then talk a little bit about how you can get in touch with her or us going forward. So here, let me play this.
Hi, I'm Taylor.
1 second. Okay. Oops.
Hi, I'm Taylor. I am 16 years old from New Jersey, and I'm an ALD carrier. My dad was diagnosed with ALD when I was 3 years old, and he passed away when I was 5. I found out that I was a carrier gradually. My mom did a lot of work with a nonprofit organization to raise money and awareness for ALD, so I've known that I was a carrier since I was about 7 or 8, and I understood as much as I could at that time. When I was 12, my mom took me to the Kennedy Krieger Institute to speak with a genetic counselor, so ever since then, I've basically known all there is to know about being a carrier, and I'm glad that I found out at a young age. Instead of being surprised with it when I'm a teenager or older, I've never really been afraid or upset about it. I know I might get symptoms when I'm older, but knowing now I can take precautions and I can eat healthy and I can exercise. And I also know that I'm going to have to explore other methods of conceiving children. But learning early will make sure that I'm prepared for the future. And I think that there are some positives that have come out to me knowing that I'm a carrier. I've learned to be an advocate for ALD, and I've learned to take action, and I've learned to help people and to get things done. For example, I've done a lot of testifying in New Jersey, and I got to speak in front of the House and the Senate, and I even got to talk to Governor Christie about signing a newborn screening bill into law. I've been active in raising awareness and money for ALD since I was in 4th grade, and knowing that I'm a carrier has really been what's fueled me to do that. So in a way, I feel that knowing that I'm an ALD carrier has made me into a better and a stronger person. It did in no way ruin my childhood whatsoever. I am happy that I know, so I can be prepared for the future, and it's kind of sculpted me into the person that I am today. I know that all girls aren't the same, but personally, I am glad that I knew when I was young, and I wouldn't have wanted it any other way. And finally, for any teens or young women out there who are on Facebook, I recently started a closed Facebook group called YAC, which stands for Young ALD Carriers. It's for carriers under 21 to meet, support each other, share information, and advocate for themselves and other carriers. So if you would like to join, just look us up on Facebook. If anyone has any questions for me personally, I would be happy to answer them. Thank you.
All right, so the information about Taylor's website and her Facebook group, rather, is depicted on this slide. So, I think that was really brave and really important of Taylor to share with us her experience. Certainly, there are all different types of young women out there who may feel differently than Taylor, but I think, what Taylor's done to start this group is really important and special, and should be thrilled to hear from anybody who would like to follow up with her. So thank you, Taylor, for that. So to just conclude this webinar, before I take some questions, I'll just remind you again about our Patient Learning Academy on Sunday, March 8th, where there'll be information about clinical trials, mobility devices, exercise, diet, and nutrition. Please contact info@aldconnect.org for more information about that. Also, for those of you who are interested in connecting with us after this, certainly visit our website, www.aldconnect.org. We're also on Facebook at facebook.com/aldconnect. And again, the email address is info@aldconnect.org. And as a reminder, just as we conclude the informational part of this webinar, the information and services provided by ALD Connect are for informational purposes only. I'm going to answer some questions now, and this disclaimer applies to those questions too, and those answers too. We're not intending to substitute this webinar for professional medical advice, diagnosis, or treatment. This is really just to help you have the tools you need to have a better discussion with your healthcare provider. If you're ill or if you suspect you're ill, please seek professional medical attention immediately. And none of the products, treatments, procedures, or products that I've mentioned in this webinar are endorsed by ALD Connect. And this webinar was voluntary and it was recorded. It may be available for broadcast at a later time. So with that, I'm going to just take a few questions that have been submitted from the group that's listening right now. The first question comes from somebody who is in the UK, who's asking whether in the United States we have a lower age limit for, basically whether people in the United States can get tested for this at younger ages. And I think specifically this person is asking about young girls who are at risk of ALD, and basically, in the United States, are we allowed to test them? Because in the UK, the age limit is age 16. And so what I'll say to that is that it's a very good question. I think in the United States, this is very much left up to individual physician discretion. Some doctors really don't want to test young women for ALD, even if they're at risk, because they know there's nothing we would do differently for those children. In boys, it's clear we would do something differently, but in girls, it's not so clear that we would. And in genetic testing generally, the professional guidelines say do not test children unless there's something you would do for them if their results were positive, because it's believed that that child deserves to have the right to make their own decisions about when they want to be tested and who should know that information in adulthood. There's a feeling that if they're prepared to be tested and if they make the decision themselves, they'll be more prepared to deal with the results. They'll be old enough to understand the results and act on them, and that it's not fair to take that choice away from a child unless there's some benefit of doing so. And I think as a general rule, that's a good rule. However, I'm a little bit more flexible, and I think many providers in the U.S. are a little more flexible. I've met many young women who are at risk of ALD, and they know that because they had a brother who died, or someone close to them in the family was very sick, and they're so nervous about it that the risk of not knowing is actually more harmful to them than just going ahead and getting that information. But I believe, in the UK, where the National Healthcare Service is paying for a lot of the testing, they're maybe less flexible because they don't want to spend money on tests that are not going to result in direct medical interventions. It's not viewed as a good expenditure of resources. So, that is to say, certainly talk it over with your doctor and find out what your doctor believes is right. Either way, counseling and, some extended discussion about testing, I think, is important whenever you're considering testing a young woman. But really, I think it's just a question of finding somebody who'd be willing to do it if you really feel strongly that it's the right thing to do. Okay. The next question is, how frequent are the spontaneous mutations in ABCD1? So that's a good question too. I mean, unfortunately, because ALD is such a rare disease, the information that we have about the precise rates of new mutations, it's actually not the greatest information in the world. Now that we're studying the disease more and more, I think we're going to get better and better numbers. But the estimate is that of all the people who have ALD, about 5 to 7% have a spontaneous mutation that was not inherited from a parent, that happened for the first time in that patient as a spontaneous mistake in them. There are also a really small number of people who we've identified who have the Mosaicism, which I referred to earlier, which is when you have some of your egg or some of your sperm cells that carry the mutation, even though the individual with those egg or sperm cells was not found to be positive. So that's less than 1% of people, but that's the other possibility. So it's not a lot. It's not a lot of people, but it's very difficult for us to predict in any family how likely that is to happen until after, obviously, they've manifested the disease. Okay, so the next question is, if doing PGD, would they implant a known female carrier? So if you do PGD, you're going to sit down with whoever works at the fertility center and have a really long discussion with them about all the outcomes of PGD that are possible. You could have no viable embryos at all at the end of PGD. You could have a few viable embryos to implant, but all of them might be affected boys, just unfortunately because of bad luck. Or you could have, a bunch of healthy embryos, some carrier female embryos, some carrier male embryos with the actual mutation, and you'd have to then decide what to do there. So they'll walk you through it, and you'll, sign a lot of paperwork saying, in this case, this is what I want to do. And most centers will allow you to choose, whether you implant a carrier female or not. Again, it's something that varies a little bit. There are some centers which are less comfortable with that. But it's certainly an option to implant the carrier female if you feel like you're comfortable raising a carrier female. And there are other centers which will, not encourage you to do that. But they certainly, will let you implant healthy embryos with no mutations detected. So again, it's something you need to talk about up front, and you'll be walked through every scenario, and you'll be allowed to make a decision about those scenarios. But there is some variability in what people will ultimately choose. Okay, and then I guess these other questions are a little bit more logistical. Certainly, yes, these slides will be available on our ALD Connect website, and so you can access them after today there. One person is just writing in to share that she is a carrier who actually found out because her son was diagnosed, and that actually raises a very good point. In my webinar, I kind of talked about these scenarios whereby the adult knew their genetic status, and then they were just concerned about whether they were passing the ABCD1 mutation to their children. Of course, that's not the only way to find out you have ALD. Another way is if you have a boy who's diagnosed with the disease, and then we test mom who has no symptoms yet or has mild symptoms, and we find out that she's a carrier and she didn't previously know. And that's obviously also a very, very hard situation, and it's a way that a lot of people find out this runs in their families. So I didn't acknowledge that circumstance directly, but certainly it happens all the time, and it's another way to find out that you're a carrier, is if your kid is diagnosed first. And then we just have one individual who's just wanted to acknowledge how much they appreciate Taylor for sharing her story and how brave she is. So I would like to echo that, because I think that's a wonderful sentiment. And certainly we were very happy to have her participate in this webinar. So thank you again, Taylor. And I think that's all for the questions for now, but certainly, again, follow up with info@aldconnect.org if you have any further questions you'd like us to answer. We'll do our best to get to them, and if we can't, we'll try to refer you to somebody who can answer them. And again, just as a disclaimer, nothing I've said is medical advice. Please seek care from your doctor or a genetic counselor if you want to follow up with specific care relating to your medical situation, and we can help you find somebody to see if that's an issue. All right. Thank you very much for attending, and please do stay in touch.